Notice I'm wearing one shoe. Notice my right hip, which is part of the longer side, is elevated to the left, so there's a frontal plane asymmetry when we look at somebody who has a functionally or structurally longer leg. Likewise, the lumbar spine has a concavity to the right in this case. Likewise, the shoulder is going to be elevated. What we would also see is there would be a slight rotation of the thoracic spine to the left, because people who have the symptoms or have the characteristics of scoliosis have this frontal plane asymmetry, have concavity to either right or left, and they typically are slightly rotated in the thoracic spine to the opposite side of the concavity, which is designed, or the biomechanical reaction, to try and keep the head and the eyes level. The first thing we need to do is work from a level foundation. It's like living in a house. You want to have a house that has a level foundation. So to make this happen, what we must do is get that shorter side up on a box or up on a step, or in this case, in a true stretch, up on the pedestal. What this will do is level out the hips. So as the hips are level, and we've had this concavity to the right, what we want to try and do is open it up. So we'll reach overhead to the left, or we can reach a bit to the left, but I like going overhead because that will open it up in the sagittal plane, open up that C in the sagittal plane. Now remember, there was a bit of left rotation of the thoracic spine. If you look at that x-ray in last week's Insight, the right hip was slightly elevated, but look at the spinous process in the thoracic spine, it slightly rotates to the left, and you have the C facing to the right. So what we've done now is open up the C to stretch this out. We're in an asymmetrical stance to get the psoas stretch, because remember, I believe that the psoas is a primary culprit that is creating or affecting scoliosis. It's not the back tissue. The back tissue is the result. The back tissue is a symptom. But what Dr. Masson of the Neurospine Institute has found when he's working with his patients and when he's operating on his patients, that there is a hypertonicity of the psoas of one side versus the other. If it's a proximal hypertonicity, it's pulling the thoracic spine laterally, and if it's a distal, it's pulling the hip up. So we've got this hypertonicity in the psoas for whatever reason it may be. What he's also found is that there's an asymmetry in the size and the density of the muscle tissue of the psoas of one side versus the other. So we want to try and stretch the psoas. Getting into an asymmetrical stance, a staggered stance, driving the hips forward, will get that psoas to stretch. But also the psoas is very close to the adductors, and also the hip being slightly elevated, often internally rotated, it's creating tightness of the adductor. So I don't just stretch in the sagittal plane. I'm going to get it to stretch in the sagittal and the frontal plane with a slight rotation, reaching up, which now opens that C. Now remember, that thoracic spine is slightly rotated to the left. I'm going to take an arm and reach slightly to the right, which now opens the side and rotates to get that spine in a more neutral environment. Then when I'm in this position, I will pull and push with the, in this case the left, pull with the right, which is creating an isometric stretch on the side that is short. But then as I pull, I'm getting an eccentric load, and I'm able to rotate and push, and I'm getting a bit of rotation as well. So we have a number of things going right now. We're trying to stretch in the sagittal plane, we're stretching in the frontal plane, and we're getting a stretch in the transverse plane. That push-pull creates this counterbalance, is creating this isometric tension, which I like to have my clients work with first. Once we get the tissue stretched, and we're in this position, now we're going to just drive a little bit from the hips, just to try and open and rotate to get the tissue to become a little bit more mobile.